And we're live in 5,
4,
3,
2, 1.
Well, good morning, everybody. I don't know whether my microphone's on. Ben, is my microphone on? It is. Good morning, everybody. It's July 19, 2023. I'm Jens Chapman, and welcome to a very special edition of the SSF STED Talks, Spine Technology Education, and the D stands for discussion, discovery, debate, discourse, etc. And today is special because we mark the end of the academic year of a lot of our young, talented colleagues, surgeons, and future surgeons. And this is like a best of the last year. Some of our fellows have already moved on to the next places of employment, so they're going to be calling in. But we have a large number of them here, and so this is a celebration of their academic accomplishments and a chance for us to say thank you, but also a chance to ask critical questions. And so we have, let me count this, 1, 2, 3, 4, 5, 6, 7, 8 speakers to go through, so I don't want to hog the stage any longer than absolutely necessary. Dr. Gavin Nixon from our interventional program, which is a phenomenal program, is going to talk about augmented reality navigation for lumbar kyphoplasty. And yes, we're frequent customers and our patients are frequent beneficiaries of your services. Gavin, take it.
Morning, everyone. I'm Gavin Nixon, the Interventional Spine Fellow here. Can I get my slides up on? Great. All right, so augmented reality navigation for vertebral kyphoplasty in the lumbar spine. So a little background on why I chose this. It's the rise of complex outpatient minimally invasive spine procedures. Kind of increases over time. The complexity of patients increases over time as they're moving to the outpatient setting. There's a need for new imaging modalities that are safe, effective, and confer an advantage over traditional approaches such as fluoroscopy. Percutaneous vertebral kyphoplasty is a minimally invasive treatment for osteoporotic vertebral compression fractures and painful vertebral compression fractures associated with significant morbidity, reduced quality of life, and an increased mortality rate up to 80% for patients within 1 year of fracture. So the purpose of this study really was to evaluate the feasibility of trocar placement in percutaneous kyphoplasty in a cadaveric specimen using a Mediviz, which is a company that utilizes the HoloLens for augmented reality assistant guidance, and try to compare it to traditional fluoroscopic technique. So augmented reality, it's a hot button. What really is it? In the literature, it's often cited as in situ holographic projection. The basic concept is you take the imaging that you've already obtained from the patient's CT or MRI. They're reconstructed in 3 dimensions, and using surface skin markers, the images are projected onto your patient. So this is useful for patients who may have complex anatomy, and it's superimposed so that you have a more intuitive understanding of the anatomy in front of you. So it uses a spatially and anatomically correct hologram combined with a planned trajectory for guided navigation, has the potential to decrease procedure time, decrease radiation exposure to both the physician and the patient for complex cases. This is all to theoretically improve the accuracy and facilitate workflow of the procedure. So to kind of give you an example of what this looks like from the standpoint of the user, this is me kind of negotiating with the anatomy. This is the scanned cadaver anatomy that I'm manipulating here and trying to superimpose that onto the actual anatomy. So it's a little bit clunky, but that doesn't really exist. That's just what I see through my lens. But that is the anatomy as it's seen. So materials that were needed for this, the HoloLens headset, the visual tracking equipment, the spine model, and the cadaver. So these here are sort of the visual trackers that come with the headset. This is the pen here that can be tracked virtually to tag your anatomy virtually. And then this is the one that gets registered on the actual cadaver itself. And then this is kind of a picture of what the HoloLens looks like. So methods, initially, we wanted to see, how well will this work on a spine model. So they printed out a 3D spine model of the lumbar spine. And essentially how this works is then they scanned the spine, and using that scan, you then take the pen that the that the tracker can see, and you would mark different spots in the anatomy virtually, and then you would tag those same spots on the actual anatomy themselves, and the HoloLens would superimpose the image. And so that was done registering at the transverse process and spinous process above and below the level that would be intervened on. And that actually worked pretty well, so that we wanted to see how will this work on the cadaver when there's not as much 3D spatial anatomy. So we use the CT imaging to get volumetric images of the cadaver, and then the trajectories were planned for unipedicular access into the vertebral body. Traditionally, it's taught as a bipedicular, but this was going to be planned for unipedicular access. So give you an understanding of kind of what that looked like. The Medivis software was a little bit clunky, but you essentially had to plan your trajectory with the pen, looking at the actual scan and pull it out. So each of these lines is the pre-planned navigation into the pedicle that was done. So then the kyphoplasties were performed using traditional fluoroscopic technique, alternating pedicle access and hand preference. The time needed to complete was 57 minutes with a radiation exposure of 37 millisieverts. We then used the Phantom protocol to virtually register the anatomical landmarks of the spinous process at and below the vertebral body, as well as the transverse processes at the designated levels. And then verified fluoroscopically by placing spinal needles at these levels. So then the anatomy would be registered. So another little example of what that actually means is there's these different dots that you can tag virtually to the anatomy, and these same anatomical correlations you do on the actual anatomy themselves. So when you tag your anatomy virtually, you're looking at your scan and you're planning to try to tag anatomy that can be tagged on the actual cadaver so that the anatomy can superimpose itself. So this is sort of what that process looked like here, trying to get the virtual anatomy to be as optimized as possible. So results after the actual cadaveric anatomy and virtual anatomy were registered, the software really wasn't able to accurately map the anatomy correctly on the cadaver. They were not to the correct scale, or they were oriented in such a way that it was clearly not aligned with the cadaver. So to troubleshoot this, I started expanding out, how much information visually does the HoloLens need? So I started tagging different areas of anatomy, the inferior aspect of the scapula bilaterally, the sacral cornu, and the level of intervention. So expanding the anatomy and the surface area essentially, and then contracting the surface area to see if the HoloLens was able to really map the anatomy correctly on a two-dimensional surface. At this point, it really wasn't able to track to do any meaningful intervention. So AR must be accurate or better than traditional modalities for it to be utilized. Surface mapping on a flat area with just visual registration data feeding straight from the headset is going to be a major limitation if it's used by itself. Without 3D referencing on the anatomy when there's skin over the anatomy compared to surgery. So right now this has got FDA, or they're pursuing FDA approval for cerebral vascular, and they are working on open surgery where you actually can tag the anatomy. But when you're just looking at the skin, it still has some challenges. Next step in future work, standardization of the bony landmarks that can be referenced maybe before the CT or MRI that's done, so that when you are superimposing it, you may also have trackers that are just done with the scan before. So right now the use case for minimally invasive procedures with this headset specifically is low, the difficulty to superimpose three-dimensional structures on 2D anatomy. And that's it.
Hey, Gavin, great job. Thank you. We'll have, for time interest, our next speaker, Mitchell, come up. But one question, so is there a difference in terms of accuracy of referencing of a CT scan versus an MRI scan? Is one more accurate than the other?
That's not something that I came across as being completely different. I think they would actually sometimes utilize both and then merge them together so that you were getting both types of data superimposed on the patient. But I didn't see anything coming across the literature that said one was better than.
And in terms of the types of inaccuracy, were they in a certain plane or were they ubiquitous in all planes?
In what I did, they were ubiquitous in all planes. It was either tilted axially, cranially, caudally. So I just had a really hard time trying to map it on the skin.
Yeah. So I think this is a very important study because we're in this era of just blindly jumping in on all these cool new technologies. We don't understand that there's a significant cost associated with them and an acquisition cost, but it's the next cool thing, and it's blindly followed in all regards, and I appreciate your honesty. Rod, any comments?
No, that was terrific, Gavin. Great job.
Thanks. Good. All right. Okay. That's great. Thank you so much. And we'll head on to one of our young students. Mitchell Young has spent, I think, a year with us now. And one of the cool things about SSF is that it allows young people to kind of get a clinical exposure. We have our mini medical school coming up in the near future also for our high school students and area students. And Mitchell spent a year here doing academic work and also helping out in our labs and setups. And we just thought it would be nice to have a brief review of his time here from an independent set of young eyes that are hopefully going to go into medicine.
All right. Can you hear me okay?
Yeah, just bring the microphone a little bit closer. These are contact.
Perfect.
Yeah. Perfect. Now.
All right. Good morning, everyone. For those of you who don't know me, my name is Mitchell Young, and I'm a research assistant here at SSF. I would like to thank everyone here for giving me this opportunity to celebrate my undergrad graduation and present to you today. This presentation is a shortened version of a presentation I gave 2 months ago, and it's titled "The Research Experience in My Time at SSF, A Message to Garcia." First off, I'd like to talk a little bit about my history with SSF. I've been involved here much longer than some of you may know or expect. My first exposure happened during the summer of 2016, when I was fortunate enough to work in a job status position with our lab manager, Gary. 5 years later, in 2021, I came on as a research assistant, mostly to help out our German spinal fellows with their research projects. And finally, I'm very excited to say that I've recently started this summer working in further capacity as a contractor and lab assistant to Gary. Continuing on, here are some notable firsts that I've experienced during my time here. The first two are from projects with the fellow who was here when I first got here in 2021. His name was Perry. This included my first editing and submission experience with his YouTube paper project, and also my first experience interpreting medical imaging and data with his corpectomy data project. I'm also very proud to say I've had my first publishing experience here with the Site Score, a paper published by Jonathan, our fellow from last year from Germany. And this paper, which again, I'm very proud, this is my first paper with authorship, is called Novel Scoring System for De Novo Spinal Infection Treatment, the Site Score Proof of Concept Study. And I just had to include this slide as well from my previous presentation. This is just a timeline of pictures during my time here. Top left picture, that is me at 15 years old working on my very first cadaver. Bottom left, that's Gary and I also in 2016. Top, I believe that's me observing one of our courses here in 2016. And these two pictures on the right are new since my last time giving this presentation. This is from a cranial project that I had the privilege of being involved with last week. Yeah. All right. Finally, I'm going to talk a little bit about the research experience and how it's impacted by being an undergrad and not having significant medical knowledge under my belt yet. This presented a lot of challenges, definitely, but also some significant opportunities for skills and growth. Some of these obstacles included paper submission guidelines and formatting, as well as how they differ from paper to paper. Another obstacle was finding my way around some surgical and medical terminology that I was not yet familiar with, especially spinal anatomy terminology. And also the more practical sense of balancing the research experience with my university experience and being able to not slack in one while succeeding in the other. As for new skills and knowledge, some new skills that I gained while I was here was my enhanced knowledge of anatomy, especially spinal anatomy, and also gained experience in the production of medical research. That's all I've got. Thank you so much, and congratulations to our graduating fellows.
Thank you, Mitchell. Great job. So the one thing I noticed is your hair has gotten progressively longer. Is there an end in sight, or at the end of medical school, is it going to be shoulder length?
Oh, I sure hope not. Yeah, I think it's about time for
I'll give you an honest question,
Okay.
a serious question. What should we do better? What could we do better to help young people? What could medicine in general do if you want to avoid the concrete nature of present people? But what could we do better?
What could we do better?
We need young people to be interested in medicine, and they're speaking from my own family. They want to go into tech. They want to jump into immediate high rewards, free Starbucks coffee kind of scenarios.
Yeah, I don't know. I think, yeah, accessibility is huge. I think it's very daunting for a lot of people to pursue not only 4 years of school after college, but then residency and then fellowship. That's not really something that could be changed, but I think just somehow making it more accessible for people. I think we do a great job here with, I've heard about our young med school coming up. I think that's an awesome idea for a program.
Yeah. I hope we can have you there. So thanks so much for your work. Congratulations. Stay in touch.
Thank you.
Next, we'll go to live to Arizona. It's a huge pleasure to have a direct link to Dr. Mauricio Avila, who was a spine fellow here from the University of Arizona in Tucson, and he did a great job here, and we miss him. Everybody in the OR is asking for Mauricio. Where's Mauricio? Well, here he is live from Arizona, and he is now in St. Louis, actually, so we're live in St. Louis. I missed that. Thank you, Rod. He has already switched to his new job. He's at St. Louis University. So from one hot spot to a hot and humid place. He is an academic neurosurgeon, and he took on a subject that I was critical of because I thought we know everything about it, the infamous phantom of the vacuum disc. And he asked the philosophical question of, does it matter? Without much further ado, hello, Mauricio. Hello in St. Louis. You are in St. Louis, is that right?
I am, yes. I was going to show you. I have my office. I have a picture, from all of you guys. So there you go.
Excellent. Thank you.
But yeah, it's very humid, as you were mentioning, and there was a couple of storms, so it's even more humid. I'm still trying to get used to it. But yeah, as Dr. Chapman was saying, I picked this topic because we see it so commonly in clinic. This was actually one of the clinic patients in Seattle, I think just before I put this presentation together. So we see this every day. It's very common. It was initially described in 1942 by Knudsen, who was a radiologist, and it was in 1942 describing X-rays. The incidence of the series is between 1% to 3%, but again, the question, which I think that's the title, is, does it matter? What do we do about it? Do we ignore it? Do we treat it? Some authors have suggested it's a sign of instability. Others have said that it's just degen changes. You can basically ignore it. It's actually not air or vacuum. It's actually nitrogen that is accumulated in the disc space. There's some newer data in the past, I think maybe 15 years, where they're doing some cadaveric studies and additional testing when they show that there is some correlation with blood vessels and poor disc perfusion getting this phenomenon. And again, as I mentioned, surgery, do we do surgery or do we not, is still kind of in debate. So what I did is a systematic review of several databases up until November 2022. In our several meetings, we talk about it and the different terms. So I basically included disc with a C, disc with a K, air disc, black disc, vacuum disc, to try to include as much information as I could. I was very surprised. I thought it was going to be like thousands of papers, but actually there weren't that many. So the inclusion criteria, again, vacuum, air, black disc, reported under series, English language, more than 3 patients. I didn't want to include any case reports. And we extracted data from the results section, the tables, the figures, et cetera. And then we pull all that information into a new table. And then with some descriptive statistics, because we didn't have enough to do more than that. A total of 169 articles were found, and 2 authors did the selection, and then we ended up with 11 articles. They were from 7 different countries, including the USA, Taiwan, Japan, Korea, Israel, Brazil, and France. And Korea was the one that had most studies with 3 in total. They were all retrospective with level 4 evidence, and all of them published after the year 2000. From all the available articles, 423 patients were included, with 51% of them female and a mean age of 60 years. 1 study performed an ALIF, and 1 was for lateral interbody fusion. The rest performed either traditional TLIF or EPLIF. And there were 341 operator levels, and this was the first interesting finding, was that L4-5 was the most common involved level with 47%, followed by L5-S1 with 40%. The articles of reported complications were 9.1%, and they have a follow-up of 20 months. The overall fusion rate for everybody, ALIF, lateral, PLIF, lateral, posterior lateral fusion, was 82%. But there was 2 studies that actually compared posterior lateral to interbody fusion, and the one that actually had interbody cages had a better fusion rate. I think it was 97%, if I remember correctly. This is just a graph showing that L4-5 was the most common level involved, followed by L5-S1. Some of the selected articles, just so you can see the type of titles and that we found during the searches. And then just again for discussion, the L4-5 was the most common level, and fusion, especially if you can do an interbody device, graft, cage, showed good outcomes in terms of bony fusion and also patient-reported outcomes for the studies that reported it. And of course, as any retrospective study with retrospective studies, there's a risk of selection bias of the patients. And then of course, just from the get-go, these patients were getting images because they had symptoms. So if you have vacuum phenomena, if you have an X-ray or a CT for other reasons, I think that will be interesting to see. Again, all these patients had issues, and then the vacuum disc was present. So, take all this information with a grain of salt. So in conclusion, the vacuum disc phenomenon is most common at L4-5 per our review, and the treatment with spinal fusion, ideally with an interbody cage, yields the best clinical outcomes and fusion rates. And in symptomatic patients, given that they get better with the fusion, the vacuum phenomenon probably represents a combination of an end-stage degenerative disease and some spinal stability. Thank you.
Mauricio, thank you again for a great job. Clinically and academically, this represents, again, a outstanding example of a clinical entity that we all see, we all know of, and we assume we know everything about it, and your inquisition yielded very meaningful results. Here's my naive, blue-eyed Wednesday morning question to you. Is a vacuum disc painful? If I go to clinic later, as you were faithfully with me so many times, and I see one of my 30 patients, and probably 15 will have a vacuum disc, can I infer that the presence of the phenomenology of a vacuum disc equals representation of back pain?
I think that's a tricky question. I think it represents that there's. I think you can say that is, and I will say instability at that level. And hence back pain. I think what it becomes even more trickier is if you have more than one level of vacuum disc. And I think that's something that hopefully between here and there, we can try to pull as many patients as we can. Is if you do one level fusion and then above it, you also have a vacuum disc, what's going to happen with that one? Or if you see 3 levels of vacuum disc and somebody with back pain, are you going to fuse at 3 levels? So hopefully you'll only get single level vacuum disc with back pain. And then I think you have a good chance of helping them with a fusion. I think it becomes more complicated if they have multiple levels and back pain.
That's a good point. So let me just harp on something that you just said for clarification purpose, and then we'll need to move on. So if I, let's say, want to do an L4-5 fusion, let's just say a degenerative spondylolisthesis with a stenosis, a typical clinical entity, and L5-S1 is a clear vacuum disc, an air disc that rattles around a little bit, but is not really unstable, there's no stenosis. Should I include that in the fusion based on what you now know or not?
The research itself wasn't able to answer that question because we only look at, like, I would call it virgin non-fused spines. I will be very actively thinking about possibly including it, just because then you already know there's something happening at that level, even though you have a clear, as you said, spondylolisthesis at 4.5. If you ever have a vacuum disc at the level below above, you know that the disc is already going some degenerative and possibly instability changes already.
Got it. Okay. Well, we certainly really appreciate your hard work, your dedication to professionalism. I know the citizens and the trainees in St. Louis will greatly appreciate you also. Where are you in your submissions? I have to put on my hat, Supervisor. Where are you in your submissions process? Can we look forward to this in print?
Yes, I'm actually going to send you a draft by the end of the week. I did some changes. So I'll send it to you for your review, and then hopefully we can submit in the next couple of weeks.
Outstanding. Thank you for your hard work. Hopefully you can stay online. If you have any comments, please let us know. We'll move on to Dr. Gerrit Lueck. He's from Bochum, Germany originally. I greatly sympathize him for many reasons, but he is a Bayern Munich fan as well. That's a soccer team in Germany. And he suffered with me through the last season, but they still end up on top. He picked up on something that's really important. Less invasive surgery has become a really big topic. And going from the side, the far lateral approach, some people call it an XLIF, other companies call it differently, has become very fashionable. If we go into the thoracolumbar junction, however, we enter a lot of anatomically challenging territory. So he actually did a novel experiment on cadavers to see what the actual trauma is if we go from a far lateral approach at the thoracolumbar junction. Gerrit, take it from here.
Thanks, Dr. Chapman. Good morning, everybody. My name is Gerrit Lueck, as Dr. Chapman already mentioned, International Research Fellow from Germany. So yeah, I want to talk about my project, as Dr. Chapman already mentioned, where we investigated the relationship of vital organs of the thoracolumbar junction during a far lateral approach using a T12 corpectomy model. So what were our purposes of the study? Our purposes were to assess the spatial relations of vital organs and the diaphragm, pleural cavity, and membranes during a far lateral minimal invasive complete T12 corpectomy. Also to assess the proximity of key vascular structures. And third, to assess the safety and injury potential of vital structures as outlined above during the insertion of the structural metal cage into a T12 corpectomy. So yeah, regarding the methodology, we included 5 fresh frozen cadavers, which were all adult cadavers in our study, which did not receive a prior thoracic or abdominal surgery before. The dissections were performed at closest possible adherence to an usual T12 corpectomy using a far lateral left-sided MIS approach. Let me just show you some pictures and to just go briefly through the procedure for time's sake. So this is what we see right here on the left is a setting for the corpectomy model. The cadaver is placed and fixed in the right lateral decubitus position. The position is adjusted until perfect anterior, posterior, and lateral radiography was obtained with a fluoroscopy kept in neutral tilt. And the important structures, which are in particularly the T12 vertebral body, is traced and marked for incision planning. Following, the skin incision is performed with an approximately 5 centimeter portion. Oh, I must taking out a 5 centimeter portion at the 11th rib, so one level above our target level, to guarantee a sufficient lateral approach. All under preservation of the neurovascular segmental bundle, which we see on the right bottom picture. Following, the exposure was performed by a blunt finger retropleural down to the rib head of the 12th rib, following by identification of the left lateral vertebral body surface, and then installing the retractor system. Here we see on the left side, we see the view in the retractor. At the top, we see the superior blade, at the bottom, the inferior blade, and on the right side, the posterior blade. Yeah, we see on the right side a fluoroscopy image during the process of a full T12 corpectomy just as always performed under fluoroscopic control. These are the results after our intervention, where we see a pretty nice alignment in the anterior posterior and also in the lateral view. And then we had completed our first step of our study. The second step after the procedure was finished was then flipping the patient around into a supine position and then doing a median sternotomy as well as a median laparotomy to allow an anterior approach to see the structures. So what we see right here in the pictures right here, in the middle we see the diaphragm right here, as well as the opening of the thoracic cavity with the mediastinum in the middle, the right lung, left lung right here, as well as already opening the peritoneum right here. And then we continue to expose the structures to really detect which structures did we hopefully not injure and to measure the distances. So as I already mentioned, we followed with the exploration of the vital structures of the thoracolumbar junction, as in vessels, diaphragm, pleural membranes, psoas and neural elements, important foramina of the diaphragm, which are the Bordalek and the Morgagni foramina, as well as the thoracic duct as the most important lymph vessel. Any injuries were recorded, and proximity to key relevant structures to this exposure were measured, even taking into account other neighboring structures. And representative illustrative pictures were obtained for educational and documentary purposes. So yeah, let's jump into some pictures. This is kind of the first picture after we opened further up during the exposure after the median sternotomy and laparotomy. We see under the number 1, we see right here our cage in the middle. Number 2 is the aorta. We see here an intact parallel pleura and an intact diaphragm right here. As we continued to go on deeper, we have a great overview right here. Again, number 4 as a central element is our cage implantation at the level of T12 after a full corpectomy. We see our neurovascular bundle structures right here, still the left lung right here, an intact diaphragm right here. And I think this is also a very detailed view that we have right here to really have an overview which structures might be at risk. We have the corpectomy T12 level with the cage right here. We have the neurovascular bundle right here, pedal pleura. We have the hemiacegus vein right here, the aorta, and here the diaphragm. All right, and this is also another picture. We see just a little glimpse of the cage right in the top left corner right here. And this is a parietal pleura injury that we caused during our procedure. And here underneath, we still see the intact diaphragm. So after these pictures, let's go on to the results. First of all, I want to show you a table just mentioning the vital structures and the median diameter and size of the dimension range. As we have a look at the results, we could see that in all of our cadavers, of the neurovascular bundle, the veins and the arteries had a pretty similar size at approximately 2.5 centimeters. The segmental and radicular nerves were a bit taller, a bit bigger in diameter at about 3.5 millimeters. Also, the aorta was a bit dilated, but we have a very old cadavers that we operated on. And moreover, we had a look at the foramen of Morgagni and Bordalek, which had a size. The Morgagni was, according to the anatomy that we know, a lot smaller, with a median diameter of 10 times 24 millimeter, and the foramen of Bordalek with 20 times 30 millimeter. And the thoracic duct was slightly bigger than we find in literature, with 4.2 millimeter. All right, then continuing to the most important safety distance and injuries of our structures. So at first, having a look at the diaphragm, we were pretty happy that no injury of the diaphragm was detected. So in all of our cadaver surgeries, we had no injury of the diaphragm. Moreover, we had, unfortunately, in all of our cadavers, at least a small injury of the parietal pleura, ranging between 1 times 1.5 centimeters to 3 times 4 centimeters, unfortunately. The visceral pleura was always intact. Also, the neurovascular bundle was also always intact. The aorta also showed no injuries, but in one cadaver we had a very small distance of only 7 millimeter safe zone to the aorta. Moreover, we had a look at the thoracic duct, which, as we know, is on the right thoracic side, but could also be injured during the full corpectomy process. There we also saw no injuries, and also not at the esophagus. So just to conclude, despite we did a whole T12 corpectomy, we couldn't detect any injuries of the neurovascular bundle, and this is remarkably, especially because considering that all the procedures were performed by junior surgeons, for sure under supervision of neurosurgical experts, but all performed by junior surgeons. No diaphragm injury in any of the procedures could be detected, and even we found out that even a L1 corpectomy would not have interfered with the injury because of the dome-like shape of the diaphragm. A preservation of the nerve root of the target level and levels neighboring, which are T11 at L1, also did not play a role, and also no injuries of the aorta, hemiphagus vein, and the thoracic duct could be detected. Thank you.
Very nice.
Yes.
So it's great that we have one of the 3 pioneers of far lateral surgery here, Dr. Rada Skuyan. You're one of the senior authors on this project, but what are your thoughts? Is this an encouraging insight? Does this help? How does this help you?
Yeah, I mean, I think, Garrett, this is a terrific work that you've done. And if you go back a couple slides, I mean, I think the main issue is, and we looked at the literature, there really is not a lot about thoracolumbar approaches and the anatomy and the visceral structures. I think for me, the key thing is that, you know, because of the anatomy of the diaphragm, usually it's not a diaphragm injury that's the problem. Yep. What I have trouble with is exactly what you had here. Usually you have almost 100% of the time you get some injury of the pleura. The difficulty is, and again, I've had cases where, and this is why I think is important, Garrett, is you always want to make a clinical correlation, is that if you injure just the parietal pleura, why would you get a hemothorax? Yeah. And so that does happen, or pneumothorax, you know, and I think because you're working outside the chest cavity, but then you're going in it, you're creating this kind of artificial space that doesn't exist. And I've had a couple cases where, you know, you go, oh, I didn't even, because we usually sometimes drop the lung when we do that. We have a double lumen endotracheal tube. So we'll drop the lung on one side. And then at the end, when you get a chest x-ray, almost 100% of the time they'll have a pneumo, but then usually the lung reinflates. Now, sometimes you'll have a case where the patient actually gets a pneumothorax. And then if you get a CT scan, you'll also see some fluid there, which is not really, you know, it's part of the surgery, but then they'll call it a hemothorax or pneumohemothorax. And so for me is there injury to the visceral pleura as well? Because to me that must be happening, or is it that basically we're not, you know, the lung is not re-expanding because we're creating this artificial space. So I think that's one thing to consider, but otherwise I think it's a great project.
So Dr. Mark Dekotowski, our long-term friend, great colleague, and he's been a former faculty also, asks, and again, I want to have this clarified. I think you said it, but he asked, what was your intended dissection space? Was it in the retrocrural space and working cephalad, or did you dissect dorsally through the crus directly over the rib head?
So our
Can you speak in the microphone? Sorry, a little bit closer.
Oh, sorry. Our target level, as I mentioned, was the T12 corpectomy. So our dissection level, we went 1 level higher. So at the far lateral side of the T11th rib to take out this 5 centimeter portion, and then making this blunt finger exposure just retropleural to the rib head. And this is how we performed the dissection.
Can you show that overview picture again? So yeah, for me, who does not perform these far lateral surgeries, there are a couple of amazing insights. Yeah, this one, yeah, yeah. This is really very telling because again, the surprise for me was that you did not have to actually violate the diaphragm at all.
Yeah.
And even if you, this was T12, even if you went down to L1, did you have to cut the diaphragm?
No.
No, you don't.
Cases not.
So Mark, the answer is you don't actually have to cut the diaphragm if you're on top of it. And exactly, so the diaphragm is actually not violated, believe it or not, and it's a dome-shaped thing. It actually originates much lower. So this is kind of a surprise. For me, the other thing was that you don't have to actually violate the neurovascular bundles. You can preserve them. If you dissect your rib off correctly, you can actually preserve it. That's an advantage to the conventional surgeries. Definitely. And go back to the fluoroscopy shot. So for me, another indirect thing was, I want to say, I want to express my strong appreciation of our fellows. So these surgeries were total, the plan was total T12 corpectomies done by fellows who are instructed in the technique by Dr. Oskuyan. They did these surgeries. They did near complete corpectomies at T12, as you can see. There were no recorded neurovascular injuries whatsoever. That for me is pretty astounding. So I thought that's noteworthy. So Rod, are you going to put a chest tube into, if you do a T12 corpectomy next on one of my trauma patients, are you going to do a chest tube?
The reason we put a chest tube in actually is so you get fluid collection there. So it's get the fluid out, and then it does help the lung re-expand. So that's really the reason I put them in. But if you go back, Garrett, to that one slide where you can see, show the one where you can see the lung. See, this is great. See one there, Jens?
Yep.
So to me, what's amazing is see that clear membrane on the lung? Do you know what that is?
You tell me.
Visceral pleura.
Yeah, visceral pleura, of course.
So if you injure that, that's where you get a pneumothorax. Now, if you just injure the parietal pleura, you shouldn't get a pneumothorax, right? Because the lung can reinflate. To me, the big question is why do you, in some of these cases, is it because we collapse the lung and it takes a while for it to reinflate, or is there really a pneumothorax there? And I don't know, like I was saying, sometimes we collapse the lung when we do it, sometimes we don't. But oftentimes with corpectomies, I will leave a chest tube because a drain, if you put a drain in, it's not going to do anything.
So Dr. Dekotowski is really harping on this, but I think that you need to, for your project to be submitted, you need to have a nice diagram also, because this is a learning point for me also. How he says the diaphragm attaches T10 to L2. How can this stay intact? Do you take down dorsally? Do you take it down dorsally at the ligament portion of the diaphragm? Show him on this diagram where the diaphragm is. Where's number 7? I know it's not.
That's here, the number.
This is number 5.
So it's really because of this dome-like shape. We see that the highest intent of the diaphragm might be at the height of, I don't know, T12, T11 or something. But because of the shape, it's really inserting at the vertebral spine right at the. So in our cases that in our cadavers, never higher than L2, actually.
So never higher than L2 is the dorsal attachment, Mark. So it's truly a dome sphere that rises. And so the attachment is actually at L2. Is that correct?
It's correct.
Because you could do an L1 corpectomy without actually violating the diaphragm.
Yes.
We always do.
We always do. Dr. Oskuyan says it. So thanks for your insistence, Mark. Otherwise, we have to fly you back out here to Seattle to show us differently, okay? But here's the evidence, and Dr. Lewitt would not lie, would you?
Yeah, definitely not.
He would not.
That's for sure.
All right, great discussions. Thank you. Great job, Garrett.
Thank you.
Must move on. And Dr. Jared Cook is going to talk about multi-rod constructs. We do a lot of complex revision surgeries and deformities and tumors. And he has investigated whether the literature actually supports the use of multiple rods or whether we just have to do a better job with our biologic fusion attempts. So let's fire away, Jared.
I'm Jared Cook, one of the orthopedic spine fellows here. So my project is called Are Multi-Rod Constructs Better at Preventing Rod Fracture and Pseudoarthrosis than Standard 2-Rod Constructs? This is a Prisma systematic review and meta-analysis. I have no disclosures related to anything. This is currently submitted to Global Spine Journal, and it is registered with Prospero. The reason why we did the study in the first place was because pseudoarthrosis and rod fracture are commonly encountered, in the deformity world, and hardware failure is reported in anywhere from 6 to 33% of adult spinal deformity patients, and they can end up with pain, loss of correction, soft tissue, neurologic compromise, and reoperation as a result. The problems, they tend to be more prevalent in areas of high mechanical stress, such as the lumbosacral junction and areas of 3-column osteotomies. Several studies have been done to try to decrease the risk of these problems by applying additional rods to the conventional assemblies, but no systematic review has been done prior to this. So the objective of this study was to investigate the usefulness of multi-rod constructs compared to standard rod constructs, which we'll define as a 2-rod construct. Outcome measures that we examined were pseudoarthrosis, rod fracture reoperation, and PJK/PJF. It's not really defined in the literature, the differentiation between, just the kyphosis and failure. As an aside, we wanted to look at the indications that these multi-rod constructs are being applied for, and look at the terminology that's being used. So everything was done in accordance with the PRISMA statement. IRB approval was not required for this. The eligibility criteria were adult human live patients with posterior only constructs and a minimum of 2-year follow-up. The exclusion criteria basically, children, non-segmental fixation, any animal cadaver, in vitro, finite element analysis, and also anything with less than 2-year follow-up. So the search strategy was looking at PubMed and Ovid databases. Automation was used for full text in English. So here are the terms that were used. We included every term that we think of and find for a multi-rod construct, including things that seem to be used a lot less, like outrigger and jump rods, such like that, and also excluding pediatrics. The study was conducted with 2 reviewers and a tiebreaker in case there were any disagreements on what studies should be included and excluded. We looked at the surgical indications, number of levels fused, number of rods used, the regions of the spine fused, such as cervical, thoracic, thoracolumbar, et cetera, length of follow-up, and then the rates of those outcome measures that we discussed earlier, as well as the rod terminology. Statistical analysis was performed by our statistician. Odds ratios were produced, and based on what's available, in the literature, the meta-analysis was performed looking at short-term and long-term follow-up groups. The short-term being less than 37 months, long-term being greater than 48 months. There was nothing in between. So that's how those groups shaped up. So the study initially found 2,754 studies to look through. There was quite a bit of ophthalmology in there, I guess, looking at rods and cones. So once everything was sifted through, 10 studies were identified that met eligibility criteria. Here's the demographic and clinical data from that. Shows that most things were, everything was level 3 and level 4 evidence. Mean age was similar across both groups. The percentage of males, the indication was overwhelmingly adult spinal deformity, and almost all of these were thoracic to pelvis fusions. None of these involved the cervical spine, and average number of levels, or mean number of levels fused in the multi-rod construct was 11.4, 9.9 in standard rod construct. Multi-rod tends to be 3 to 4 rods, not more than that. And follow-up was anywhere from 2 to 6.5 years. So our outcome measures, showed that the rate of pseudoarthrosis appeared very different in the multi-rod versus standard rod constructs, as well as the rate of rod fracture, with it being about half in the multi-rod construct group. So reoperation followed accordingly, and we also saw there was no real difference in PJK, PJF between the two. There initially, the reason why we looked at PGK and PJF was because there was a thought that too stiff of a construct would lead to increases in junctional failure. And so this has shown us that that's not really the case. And so the odds ratios produced show that in terms of rod fracture in the less than 37-month group that you can see here, there is a statistically significant difference favoring multi-rod constructs, and then with longer-term follow-up, there is an even bigger difference that can be seen in terms of pseudoarthrosis. We see there also is a statistically significant difference. Reoperation, as I said, follows accordingly, and then PJK, PJF, no difference is seen. So then those other things that we looked at in terms of rod terminology, multiple rods, satellite rod, accessory rod, supplemental rod are the kind of most common ones there, but kind of ran the gamut, and there was no consistency. The limitations on this are that there was a lot of heterogeneity among the studies. You could see that in our reporting of our forest plots. We're dealing with level 3 and level 4 evidence. There's not really standardized reporting of the rod constructs, so we could have missed things in our in our initial study search. We see that longer term follow-up is needed. Basically anything that is less than 4 years, you kind of run the risk of reporting too low of an incidence of rod fracture and pseudoarthrosis. And so we really need much longer follow-up than our kind of minimum 2-year follow-up standard. In addition, there's kind of a lack of trauma, neuromuscular, and oncologic populations in this, as it was almost exclusively adult spinal deformity. And then looking at rod materials and diameters, looking into these studies just qualitatively, there was no consistency if they were reported at all. Some were cobalt chrome, some were titanium. Diameters were different. There was no consistency among even similar populations. So we can't draw any conclusions based on that. So our final conclusions, multi-rod constructs show us that there's a decreased rate of rod fracture, pseudoarthrosis, and reoperation. No difference in proximal junctional kyphosis or failure. We need a longer-term follow-up to see the true efficacy and magnitude. Over time, we have seen an increased, interest in multi-rod constructs, but we need common language in order to improve our reporting practices. So that is it for me.
Great. Thank you, Jared. Congratulations. Dr. Cook had to move on. He is already relocating to his new home in Virginia Beach, and so we thank him for his work, and this will be, it's already been submitted for publications and peer review right now. Rod, does the insight of this study, which was somehow not done before, change your practice? Are you gonna do more multi-rod constructs?
I mean, it's really fascinating to me because, again, when do you use it, how many rods do you use, and then I think the configuration makes a big difference. I think just putting in a bunch of rods to me doesn't make any sense.
Yeah. So, I mean, we see, I think both of us, we exchange a lot of views. We see a lot of crazy assemblies that I'm not even sure how to call them outside of jigsaw puzzle or Jenga or whatever.
Yeah.
So this is an emerging thing where we need to try to get to a better professionally guided nomenclature that's more consistent, right?
I totally agree.
Yeah, and I thought for me this is very helpful. For me, the other great insight was that the incidence of proximal junctional failure is not affected. So by stiffening up the surgical reconstruction site, there's not a greater failure proximally, and this is, I think, a important insight also because it does address the veracity of the study. Life in spine practice has changed dramatically over time, and as a young surgeon, and Dr. Chris Seidel, who's our next speaker's age, thoracolumbar fractures were a prerogative of the 30 and 40-year-olds or younger who did crazy stuff or had bad luck at work, and this has now changed into a 70, 80-year-old plus clinical clientele. And again, Chris was on call with me the other day, and I think we had 4 or 5 thoracolumbar fractures. So we thought we'd look at, and he thought the topic that interested him most was what is going on with thoracolumbar burst fractures and what are the risk factors of readmission? So Chris, tell us what you found.
All right. So as mentioned, my project here is thoracolumbar burst fractures and 90-day risk factors for readmission. I don't have any personal disclosures. Some of my attendings have some disclosures. So most acute thoracolumbar fractures result from a relatively high energy trauma. The initial force gets absorbed above and below the injury site, and indirectly it gets transferred through the thoracolumbar spine. The maximum canal occlusion and neural compression at the moment of impact occur right at the level where the conus and the cauda equina are. But there's a lot of tissue recoiling post-injury that can minimize the extent of the displacement on presentation. These are significant force injuries. They usually have concomitant injuries involved with them. Readmissions have significant implications here, including increased healthcare costs, decreased patient satisfaction, and potentially adverse outcomes. So the goal of this study was to investigate the rate of and the factors contributing to hospital readmissions in these patients, and hopefully learn some potential strategies for reducing the readmission rates. So this was a retrospective review using the 2018 NRD data. We had ICD-10 codes to identify the patients. We looked at patients specifically that were over the age of 18 with a single level thoracolumbar burst fracture. You know, that's from T11 to the L2 in ICD-10 coding. We assessed demographic information, and whatever factors we could associate with readmission were collected. Patients that were treated operatively, non-operatively, and who were readmitted and not readmitted were all compared, and statistics were done by people much smarter than me in statistics. Okay, we also, importantly, we excluded polytrauma or patients with multiple burst fractures. The procedure codes we used to kind of distinguish operative versus non-operative was spinal cord decompression, lumbosacral nerve decompression, vertebral discectomy, and spinal fusion. So what we ended up with was about 4,500 patients. The total number of readmitted patients was 307 for a readmission rate of about 7.5, which is consistent with most elective spine procedures in the literature. Male sex was a significant risk factor, as well as age, particularly the 60+ age group made up the vast majority of those readmitted. Medicare patients were identified as having higher rates of readmission compared to other payer types. Interestingly, operative treatment at the initial injury was a significant risk factor for readmission as well. Of all the comorbidities that were listed under the patients, obesity was the only one that was found to be associated with 90-day readmissions. So the conclusions I was able to draw from this are, obviously, these are increasingly common. There are patient-specific factors that are associated with readmissions, and these are important for determining appropriate treatment and patient counseling. And understanding these factors contributing to readmissions can help develop effective strategies, hopefully to prevent. I don't think this goes as far as to say who should and shouldn't get any surgery versus non-operative treatment, but in terms of helping us reduce these readmissions, it does arm us with information when you're counseling those patients during their initial presentation, and gives us a framework for how closely some patients need to be followed versus others. This has several limitations, most of it being because it's a database study. So comorbidities that were not entered as diagnoses during the time of readmission will be missed, nor do we actually know what the primary reason for readmission was. Similar database studies are limited by in-hospital events only. So consequently, the true incidence of these complications or events that occurred after the initial presentation that didn't involve inpatient hospital care can be grossly underestimated. And lastly, because we can't see imaging or don't have any access to notes, we don't know who was indicated for surgery and why. These are some of my references. Yep.
Great job. Thank you, Chris.
Yeah.
Thank you.
Can you go back to the survey picture? Yes, I think this one was very important. So in the big picture, let me just ask you, this is a taxpayer-based, very large database that's supposed to be all comprehensive. How easily accessible was it? We obviously have a subscription for it, so you have to pay to look. How meaningful was your interaction with this? Did you, as a taxpayer and concerned clinician, find it a useful database?
I found it very difficult to work with. It's very statistics and data heavy, very, very large spreadsheets were involved. I had to enlist the help of people who were very knowledgeable in using those types of databases just to digest this information.
So this is an important insight, I think, because again, this is the reality of big data is there's a vast accumulation of data. Dr. Skui and I have called it data swamp, whereas there's just a large number of points, data points put in there, and it's not clear how well they've been curated, so data cleansing. And then the analytics are difficult. Like, how sure are you that there are no spinal cord injuries in there?
You can't be sure at all. You are at the mercy of what was put into the chart and what was recorded into the database.
Do we know why patients were readmitted, actually?
No, that was one of the main limitations. You don't have any idea of what the readmission diagnosis was, just that they were readmitted.
Okay. Do we have any idea? I keep going on with questions. So you have length of stay, 7 days, and non-readmitted, but do we know how long the readmissions were?
No, we don't.
Yeah, just so readmissions in the US has become, and we have so many international visitors, and I'm looking through the chats and the participants group. So thank you all for your interest. We have many, many good friends here from around the world. So thank you for your interest. But here in the US, readmissions have been named one of the leading quality criteria. Yet again, we don't know why. So Dr. Korovesis, Panagiotis Korovesis is asking, why would Medicare patients have more readmissions? So you've been working here very hard for a year. Great job, by the way. You've seen the daily reality of our elderly patients. Why do they get readmitted? What is your clinical experience that you can try to superimpose on the statistics?
Yeah, I think these typically older Medicare patients have more comorbidities involved. They're usually frail. Those are usually not high energy injuries. They can be very low energy, just ground level falls sometimes. And I think they just kind of fall into that category of these are frailty injuries for them, and they're not able to tolerate the injury or recover from surgery for it, even as well as a younger patient, maybe.
And I'm going to ask you a question, and I'll ask Dr. Glenn David to comment on that. Do you know if procedures or non-procedures actually mattered? I think you addressed that, but I want to just have you clarify that one more time. Did it help to have surgery? Did it help to have, and here's the tangent, or the segue to Dr. David, did it help to do vertebroplasty/kyphoplasty?
I did not specifically look at vertebroplasty or kyphoplasty. That wasn't one of the procedure codes we looked at, but what we did find was that patients who had been treated operatively were at a higher risk for 90-day readmission.
Okay. So Dr. David, if you can use one of the big microphones, yeah. Dr. David is the Chief of our Interventional Services. Rod, can you pass him the microphone? Yeah. So we're sure that he can be heard. So he's the Chief of our Interventional Medicine. In our country, is it clinically meaningful to actually give these older patients vertebroplasties/kyphoplasties while they're inpatients so that they can get moved on and kind of move ahead, or are there financial barriers? This is a non-reimbursed type of a management.
I think trying to get the procedure done as quickly as possible while in-house is definitely a benefit. Definitely having problems getting clearances and insurance approvals once they get into the outpatient setting. If it could be done in the inpatient setting, it'd be definitely a benefit to the patient. They definitely improve in terms of their pain scores. The activities that return to activities of daily living is quite a bit quicker. They're suffering quite a bit less. I think it's a scenario where you want to treat it as soon as possible. The question is also, are we changing their chances of having an adjacent level lesion, adjacent level compression fracture? For those patients where we don't treat the compression fractures, they are still having adjacent compression fractures at above or below the fracture. So, the big contention is, well, you're creating another compression fracture by putting cement in. But to answer your question, Jens, is, trying to treat these as soon as possible is very definitely helpful to the patient and improves their overall morbidity and mortality.
Got it. No, so this is still a problem. We don't have a rapid response system from insurance carriers, and we can't keep patients here too long. I was amazed by the length of stay of 7 days because, again, you were on call with me over the last week, and how many thoracolumbar fracture consults did you get per day? I mean,
A handful.
Every day.
Yeah,
I mean,
day.
it's
Very common.
We're overwhelmed as is, kind of, but we would be completely overwhelmed. We could have a fracture hospital if we admitted all of these patients for a week, and yet they're suffering from these fractures. So having a more rapid response kind of a system that includes insurance carriers, because again, many patients would benefit probably from an earlier cement augmentation. Dr. Dekotowski again pointed that out. And again, putting them on a far more aggressive osteoporosis screening program and then pharmaceutical intervention program with osteogenic agents such as teriparatide, for instance, or their newer variants. So that's a really big deal. And again, we do need to watch out for that. But again, as Dr. David said, kyphoplasties can increase the risk of adjacent segment fractures. Yeah, Dr. Dekotowski pointed that out also. So it's not a panacea, but it can help, right?
I think it definitely help with the patient get done as soon as possible.
Yeah. Great job. Thank you, Chris.
Thank you.
We have two more lecturers, and it's great to have Dr. James Hicks talk about one of those things that we all see as spine clinicians, and that, interestingly, has never been really thoughtfully assessed and classified. So Dr. James Hicks is from Alabama, from the great University of Alabama, and he's going to go back to Mobile, Alabama, and going to be a leader in spine surgery there. So, and he's known for his large fonts and evocative slides. So we're looking forward to another
very tame,
high imprint, visual imprint lecture.
Yeah, so here we go. So a bit of a, so here's our graphic here, pedicle screw loosening. So we're going to propose a clinical grading system. Thanks to everybody who's been involved, which is just about everybody here. So introducing it, high rates of screw loosening in the literature, and it does lack a grading system. It's important for the system to recognize the severity and to create a language to discuss management. So a good grading system has good content, it's reliable, valid, and ideally helps direct treatment and is actually memorable. Our goal is to create such a system. So diving into our methods, we did a retrospective inquiry from 2010 to 2022 for screw loosening and TL constructs. The grading scale was created using the Delphi method, which is essentially a group of experts coming towards some sort of consensus of a list of a grade. This was tested with survey and questionnaire, and the validity, accuracy of the scale was tested. Secondary management / the use of this scale was also evaluated and surveyed. So our grading scale included grade A, being inconclusive evidence of loosening. Grade B, radiographic evidence of loosening. Grade C, severe pedicle erosion or screw pullout. Grade D, complete obliteration of the pedicle / unsalvageable pedicle. And grade E, a screw fracture. Here's an example of the survey that was sent out to providers to evaluate. There were clinical scenarios below, a list of x-rays and CT scans and various cuts to determine how the rater would grade the amount of loosening or if they thought loosening was present. And then there was a series of questions afterward to determine clinically how they would manage this patient and if there's anything significant there we could evaluate. So here's an example of some films at the bottom of that survey. So underneath those questions, you would have films and x-rays, CT scans, various cuts, as you can see here. Other significant questions we had was how you would manage, there is an example of the list of choices that you would have in the survey, including cement augmentation, upsize the screw, utilize a bone dowel, or for pedicle salvage, or something of the sort, and or skip level, meaning adding on levels. Another significant question is if they were applying an A, B, or C grade, what were they really determining as why they would label it an A, B, or a C? And so this gave me, the reviewer of the surveys, an idea of what folks were seeing and thinking. So there's a lot of stuff in the literature, whether it's a shadow or 1 millimeter lucency, et cetera. So this helps delineate some of that from the literature. There's hailing around the screw that's close to 1 millimeter in radius, seen on CT, as you can see here. Evidence of hailing on CT and radiograph, obvious windshielding of the screw, and the pedicle is eroded, anatomy is disrupted with alignment concerns. So these answers were gathered, listed, a consensus was stated, and statistics were run with different reviewers as an accuracy rater. Got some data back, and so we have some decent numbers to discuss and probably some interesting topics of discussion. So when we compare a random person's survey to the group consensus of particular answers in the survey, you get some correlation coefficients. And so this gives you a good idea of what people are thinking and if they either agree with the consensus or not, and what is their rate of correlation there. And so in conclusion, the scale has essentially been validated. So we've taken a group of experts, we've created a grading system, we've given out surveys, and those people tend to agree with the consensus in those surveys. Defining the management of screw loosening, I think, is requiring further research and investigation. But preliminarily, it appears that there's a strong correlation with a random reviewer agreeing with a consensus on grade, also with the radiographic evidence that's present. The decision to operate is less correlative as the others. But there's also, when you do decide to operate, there's good, strong correlation with how to manage that surgically, given the options that we have in the survey. And that's what I have.
Very good. Nice job. Thank you, Jim. So tell us about a correlation grade. So 1 would be perfect?
1 would be perfect.
So how do we rate 0.87, for instance, correlation grade? Is that good? How does statisticians view that?
So I did have to lean on some statisticians. 1 would be perfect, meaning everybody's agreeing with everybody. And you take a random person, they would tend to agree with everybody else in the survey. So 0.87 is pretty good.
I thought so.
Yeah.
Yeah, I thought that's actually, I have not seen these numbers before, I must say, so I thought that's good. Can you go back to your slide that shows the grading scale? So go back a couple of slides. So I thought this was a really interesting question. Now you had a classification, his classification slide. Yeah. So one of the problems that we nowadays have with digitized x-rays is there seems to be kind of a halo effect that may or may not be real on some images. Any thoughts on how to validate that? Should we kind of, are there any tips and tricks that you have? Do we have to resort to CT scans?
Yeah.
Are they better?
Yeah. The best way I thought to address that is if you take a large enough group of people and you give them enough x-rays, they're somewhere between an A and a B, you may come to some conclusions that's real or not. The third survey that was sent out was focused on this between A and B. So if there's inconclusive evidence or actual evidence of loose things, I think that's basically what you're trying to get to there. And actually most people agree between A and B fairly strongly whether or not there's actual evidence there if that hailing is real. We've yet to delineate that fully because that third survey is kind of in its beginning stages of statistical analysis.
So are CTs then better than plain x-rays in terms of
Yes.
assessing that?
Yeah, they are. But there's still something to be gleaned from an x-ray. The overall alignment, there's no replacement for plain radiographs as well.
So yeah, so that is, I think, a very important take-home point. Rod, how does this help you as a clinician? So now we have a classification system, if you go back to your classification system, and there seems to be a pretty good consensus as to assessing this, but there was not such a strong correlation in terms of how to intervene, right?
Right, yeah, the biggest thing being the decision to do surgery or not.
Yeah. So Rod, why is that? How does this help you as a clinician now going into the OR later today and doing some complex revision surgeries?
I mean, I think it's more common that we get CTs now, right? And so the real difficulty is, what do you do in a patient who has, let's say, a grade B, and you know they're going to grade C and they're not symptomatic? I think that's the real difficulty, is what do you do with patients? Go back to that one image. I mean, maybe they don't have symptoms and their x-rays look like that.
Right.
So Rod, what was this in your thing? Was this a grade D? Was this it's not broken, but is this a salvageable one?
Well, again, if you look at the Hicks grading scale, I believe that I don't have the CT scan, but it looks like it's grade D, going on probably E.
Yeah,
and already disconnected at the bottom.
Right, and that's the thing, right? Is how to manage that surgically. If you skip a level, does that mean it's a grade D? It's a tough thing to determine. So.
No, normally I don't see these patients in my clinic.
Yeah,
but it's other patients usually I see.
Yes,
complex.
So where are you now in the publications process?
Yeah, so finishing up some writing, and then I think the first two surveys that were sent out have good data. That third survey, delineating A and B, and that real haloing that you were mentioning, we'll kind of be following that. So hopefully publication soon.
So Dr. Korovesis asks, is there a correlation of pain, and I know you didn't assess that, and screw loosening?
Yeah, so that's, we did not, I guess, differentiate that yet. So we have a group of patients we're able to look at. This is more the survey phase and delineating the scale phase. If we were to look at more secondary outcomes, like if patients had pain with certain grades of loosening, that would be something secondarily we could look at.
So I want to really call out Dr. Hicks on having done something that is around our clinical practices all the time, but nobody had actually looked to quantify. And this is the basis to draw the next step from, which is clinical impact on patients and surgical impact in terms of how do we manage those? Right. Do we observe? And if we intervene, how do we intervene? Mm-hmm. So I want to congratulate you on that project idea and pursuing it. And hopefully we'll get this into print soon.
Thanks. Yep. Team effort.
Right. Thank you, Dr. Hicks.
Mm-hmm.
And we'll close out this best of potpourri, and I thank all the many colleagues from around the world for their commentaries. And we've had so many nice statements. Dr. Korovesis did a great job talking to us also. I want to recognize him, hope all is well in his home country. we have Dr. Schlaudruff talking about something else, and that is with multi-rod constructs, going back to the Jared Cook lecture on multi-rods. We see a lot of new components and pieces introduced by industry, and we want to see whether they actually help affect biomechanics of the spine or if they're just adorations. So let's just take a look at Dr. Schlaudruff's lecture, and he's not here in person, so we're going to pipe this in by video.
I'm Abe Schlotteroff, one of the fellows this last year, going to talk about my research project, looking at the biomechanical testing of supplemental quad rod constructs spanning rod-rod end connectors. It was a finite elemental analysis. Brief introduction: adult spine deformity surgery is increasingly performed worldwide, particularly over the last decade. What we see with these that oftentimes there'll be PJK, PJF, where previous constructs have to be extended up cephalad, which require connectors. So the previous fusion construct doesn't have to be fully exposed. A lot of times multiple rods with different connectors are used then in these ultimate final constructs, sometimes multiple iterations. Unfortunately, hardware failure does still remain high, especially in medium to long term, especially if there's osteoarthrosis over multiple levels. Hence the need to evaluate the best uses of instrumentation. So revision surgery in these cases, like I said, sometimes can include end-to-end rod connectors. So methods, what I did was a three-dimensional finite elemental analysis. I used this based on a modified ASTM F1717 spine implant testing protocol. And we now analyze the mechanical behavior of three separate screw rod construct configurations. The focus was on the rod end-to-end connectors, looking at their point of failure and strategies to strengthen the hardware. The first model, which I'll show in a figure later on, looked at just a standard screw rod construct without a connector. The second one looked at end-to-end connectors without an outrigger rod. And the third one looked at a lateral outrigger rod to supplement the connectors. And these were screws put into polyurethane blocks. I'll go over the different parameters of the finite elemental analysis. So the inner screw span was 90 millimeters. The polyurethane blocks and pedicle screw rod end caps and the connector rod interfaces were all tied surfaces. The bottom polyethylene block was fixed respect to vertical horizontal translation, but there was allowed to be some rotation along the pinholes. A static load of 280 newtons was applied at the top PE block. We only did a unilateral construct and had symmetry across the midline plane just to make the data easier to perform. And a translation rotation of the PE blocks and the stresses were recorded and compared. So with this, the outputs of the finite elemental analysis was a load displacement curve, which we compared between the constructs, stress contour, and a plastic deformation code as well. So here's the three models. On the left is case one, where there's a standard screw rod construct with 2 screws above, 2 screws below, and the ASTM model. Case two, the difference here is that we have end-to-end connectors, which are commonly used for extending, let's say like a T10 to pelvis. We have to extend to T4 for PJK. And then case three is supplementation of these with outrigger rods with dual-headed tulip screws, 2 levels above, 2 levels below, to supplement and augment the connectors. With the ASTM modeling, you can see here on the left side, we have the 280 Newton downward force. You can see this, the span between the pedicle screws there, and then also the span between the force that was applied. You can see the force factors there in the middle, and you can see which objects there are tied in the construct. So results, the first result was the load displacement curve. You can see 3 separate curves. The one on the left side is for the outrigger quad rod, and then on the middle, the end-to-end connector, and then on the right, you can see the normal screw rod construct. The normal screw rod construct had the most displacement compared to the outrigger quad rod, which makes sense that it was more rigid and had less displacement when the forces were applied across it. Here you can see a graphic looking at stress contours when the model was loaded. You can see here that Model 2 experienced the most stresses. In Model 2, the maximum stresses were 1682 millipascals and 1258 at the screw rod and the connector rod interfaces, respectively. So the maximum stresses in Model 1 construct were 1441 and 794 at the screw rod and mid rod interfaces, respectively. And then the maximum stresses in Model 3 with the quad rod construct were 948 and 685 at the screw rod and connector rod interface, respectively. So that one had the least amount of stresses. And you can see there the color configurations and the zoom in of the connectors and the pedicle screw interfaces showing where the highest stresses were placed along the constructs, showing that the highest was there at the end-to-end connectors, right where the end-to-end connector meets the rod, which is a lot of times, and the reason for this study was when we would see end-to-end connectors fail, they're usually adjacent to the connectors because that's where the highest stresses are placed, which makes sense with the finite elemental analysis. Here is looking at plastic deformation of the constructs with 280 newtons loaded. And here you can see there are variations present in the plastic deformation when they're placed under the loads. The rods in Model 1 and 2 did show some plastic deformation, as you can see there, whereas Model 3, which was a stiffer construct, did not show any plastic deformation. So this study showed that quad rod constructs confirm that they have been shown to mitigate rod fractures, particularly adjacent to areas of increased instability, such as 3-column osteotomies, corpectomies, PSOs, or in long fusion constructs, which is why they've been adopted for T10 pelvises, T4 pelvises, or adjacent to PSOs. This data shows that one should consider using outrigger quad rods adjacent to end-to-end connectors to mitigate rod fracture. And that's it. Thanks.
Great job. And as you can see from his laptop, Dr. Schlaudorff is in Idaho now, so he is already operating there like a crazy man. Dr. Oskurian, so you were the head of the study. There are so many pieces out there that industry is now doing to try to allow us to kind of attach to other rods and screws and everything like that. So what are the insights for you? This is just the simplest, most basic thing to try to attach to a previous rod. What does this mean for us? Should we kind of always use outriggers now? I mean, if you connect that with the Dr. Cook study and all that?
I mean, I think the finite element analysis that Abe did was very intriguing because we know there's these stressor points, and you know, how do we mitigate rod fractures? And I think going back to Dr. Cook's review is that I think you have to start with classification, indications, when to use it, and then how to use it. And I think right now, even industry, they've got all these connectors but if you don't actually look at the construct and see what it is that you're doing, I think it's going to fail.
I want to pick up on that. So they have to have a purpose, and the mechanical testing to this point in time is very inadequate, right?
Absolutely.
We're just given metal pieces, and we're supposed to trust them, and the actual testing has been barely able to catch up, right? I mean, this is what we're dealing with here right now.
Even with connectors, there's nobody has any data to say, okay, is a side connector versus inline better? Wedding band versus, just an inline. I mean, theoretically, you would think the inline is stronger, but we don't have any data.
Yeah, we're going to show a case of mine, I think in 2 weeks, where my side-by-side connecting system failed, and we had to do a big revision surgery. So I really want to thank you for pushing this project ahead and encouraging this. And we have a long ways to go. It's always a good sign, right? When at the end of a research project, you can conclude with the universal sentence of we need to do more research, right?
Exactly.
So I want to thank our great speakers and fellows. It's a true joy and privilege to get to work with such fine young people. And also shout out to Dr. Amanda Cecino. She couldn't be here. She is back in Baltimore. I want to thank our loyal friends and colleagues around the world, Dr. Amin Hanin, Dr. Dekotowski, Dr. Korovesis, and Dr. Lujan Medisa Madera from Uruguay. Hope you all stay cool. I know there are a lot of heat waves going around in many of your countries. And obviously, Amir Aziz, thank you always for being there. Sorry we couldn't get into all your comments, but your collegiality and your attendance and interactions are much appreciated. This weekend, we have our MIS course. I think, Rod, it's the 7th annual one. Tell us a little bit about this course.
Yes, I mean, basically, it's a great course, and you have faculty from all over the country, and it's all on minimally invasive spine surgery. So
it's, I think, last I checked, it's actually from around the world.
From around the world, yeah.
When I looked at that agenda, it was jaw-dropping. I don't know that there's anybody missed who is not a name in MIS surgery. So congratulations on
it's going to be a great
pioneering
course.
this. Okay, so hopefully we see some of you in the virtual environment for that course. And with this, we'll conclude this academic year. Thank you so much for joining us. And best wishes to our fellows.